Welcome back to Therapeutics. In this block, we're going to talk about the antipsychotics. We'll review how they're used, when we use them, what some of the issues are involving them. And I'd like to give a shout out and thank you to Peter, our resident, pharmacy resident at Cooley Dickinson Hospital in Northampton, Massachusetts, where Peter is in his pharmacy residency, first year there, and he took the opportunity to go through all of our slides here and give some updates in the antipsychotics and the antidepressants. And thank you, Peter. The antipsychotics are differentiated among into two sort of broad groups: the older typical agents, and the newer atypical agents. And they vary on how their mechanism of action, how they work, but also what their indications are and their side effect profiles. And so we'll spend some time talking about those as well. Let's briefly review schizophrenia. And I'm going to leave most of this to your behavioral health clinicians and the clinical medicine component of the curriculum. But when we think about schizophrenia, classically we look at it as a thought disorder with a multitude set of mixed symptomatology. Often the symptoms can have a subtype like a paranoid or paranoia associated with it, or catatonic association. But they're often a combination of what we consider positive and negative symptoms. So positive symptoms often are delusional thinking, hallucinations, disorganized speech. And the negative symptoms often look like depression, loss of interest in daily activities, lack of emotion, poor hygiene, loss of motivation, social withdrawal. And often you'll see both of those often pretty dramatically in folks who have schizophrenia. So the delusional differentiation between delusions and hallucinations and other thought disorders are listed here. I'm not going to go through that in depth. And the course of the illness, usually the onset is in the early 20s to later 20s to early 30s, usually a bit earlier in men than women. Patients often will fluctuate between acute episodes and remission, but they often have a dramatic impact on ability for patients to function, and the symptoms are often quite disturbing to that patient, as well as sometimes the people around that patient as well. And there might be different phases in their process of developing and presenting with schizophrenia: a prodromal phase, an acute, a stabilizing phase, and then a stable phase. And often the antipsychotic medication choice, when we find the right fit for a patient, often quells their symptoms enough that they can be considered, stable and functional, and less less distressed with their symptomatology. So important to kind of recognize what these drugs do, we'll talk about, is they suppress some of these disturbing symptoms for patients, but they don't necessarily do anything in the long course of the disease or the presentation. Etiologies of schizophrenia have long been debated. There is likely a genetic component. There is also probably an environmental component that we see that individuals who have schizophrenia who have more stressors in their lives, or trauma, post-traumatic stress. Those kind of issues are often more predisposed to schizophrenia, which makes one think this is both a nature and nurture kind of condition. The medications we use can also cause a number of to treat, can cause a lot of side effects, so those can be problematic. We'll talk about the risks with those. But there are other medications that can precipitate schizophrenic episodes as well, particularly folks that have changes, folks who take medicines or use maybe illicit medicines that can trigger a bout of schizophrenia as well. So you ought to kind of be aware of that. Many times, for example, if there's a question of schizophrenia, often you just want to rule out in a drug tox screen that there's some other etiology for what looks like schizophrenia. So as we talk about the antipsychotics, let's sort of spend a couple of minutes just reviewing broadly the classes of them, talk about how they work, and then get more specific about individual agents that are more commonly used in practice. As we think about the agents that we use, most often these antipsychotics that block dopamine receptors are classically used for symptoms of functional uh, psychosis or psychotic episodes that cause real distress to patients or the people around them. But we'll find that these medicines that are dopamine blockers have other features to them, particularly the newer agents, the second generation agents we'll talk about that work more at dopamine 1 receptors. We'll talk about that in a minute too. These agents also have more effects on the negative symptoms of schizophrenia and actually may offer some benefit in patients who are refractory to antidepressants when they have a lot of depressive symptoms. So we'll talk about their use there in the depression block. And we also see the antipsychotic sometimes used as a later resort intervention, in acute delirium, for example, in the hospital, once we sort of ruled out delirium, other etiologies for delirium as well. So we'll get the chance to sort of walk through those in a bit. The broad two classes of the antipsychotics are the older typical antipsychotics and the newer atypical agents. And both of these block dopamine receptors, but they are primarily differentiated that the older typical antipsychotics block a subset of dopamine receptors called the D2 receptors to a greater extent than the newer atypical or second generation antipsychotics that generally have an affinity for D1 dopamine 1 receptors. But they work at pretty much at these dopamine blocking receptors. Unfortunately, they also have affinity for some other receptors that cause some problems with some of these agents as well. Let's spend just a couple of minutes reviewing the first generation antipsychotic agents that block primarily dopamine 2 receptors. And of all of the ones that are listed on this chart, and this isn't the complete list, but these are maybe the ones that are still occasionally used in practice, there are only two on this list that I think are worthy of us focusing on. One is the first agent at the top of the list, chlorpromazine, which was also brand name Thorazine, was the first of the antipsychotics available in the mid-1950s. And the second agent, which is still in fairly widespread use in hospital settings, is haloperidol, the third one down on the list. These older agents are differentiated by their potency, but they're also differentiated by their adverse effect profile. And chlorpromazine at the top of the list has a relatively low risk for movement disorders called extrapyramidal side effects, which we'll review in a minute, but are pretty dramatic in its ability to cause both sedation and lower blood pressure. And it's also fairly antimuscarinic. Haldol, or haloperidol, on the other hand, is a high-potency agent which, while it doesn't have a lot of anticholinergic sedating or blood pressure changes, does have a fair amount of this extrapyramidal side effect profile, a fairly high one, which causes these movement disorders that we'll describe in just a minute. So the typical antipsychotics, these older agents, primarily block D2, a subset of dopamine receptors, to a greater affinity or a greater extent than D1 receptors. And so that's basically how these older agents are differentiated from the newer ones. But interestingly, the typical and to some degree the newer second generation atypical agents block other receptors, have affinity for other receptors, including muscarinic receptors, adrenergic receptors, and histamine receptors. So the older typical antipsychotics have affinity to varying degrees for histamine 1 receptors and can cause sedation and weight gain. For muscarinic receptors, so all the antimuscarinic properties we alluded to earlier in the year, urinary retention, cognition changes sometimes, tachycardia, dry mouth, blurred vision, constipation. They also can cause some orthostatic hypotension by its ability to block alpha 1 adrenergic receptors, and you might see a reflex tachycardia in response to that hypotension that's seen there. Blocking the dopamine 2 receptors is primarily responsible not only for their beneficial effects, but also these movement disorder effects called extrapyramidal side effects. We'll talk in a moment. And also, its effect on serotonin receptors contributes additionally to orthostatic hypertension, sedation, and weight gain. So, if you remember in basic pharm, we focused on the ideal drug would be one that binds to only one receptor and produces a very narrow set of physiologic properties. As you can see, these older typical antipsychotics bind to lots of different receptors and produce lots of effects, which is not really advantageous or desirable. The extrapyramidal side effects we refer to fall into three categories, these movement disorders that are typically all three of these acute. We'll see these within hours to days of starting the antipsychotic, particularly the typical antipsychotics like haloperidol. Acute dystonic reactions are one set. We'll describe that in a moment. Akathisia or motor restlessness, another set of side effects. And a third one, pseudo-Parkinsonism, which looks like Parkinson's disease with tremors and rigidity as well. Let's first look at one of the extrapyramidal side effects, acute dystonic reactions or acute dystonia. These happen typically within 24 hours of giving a drug like haloperidol. And it's not universal that we see this, but it happens on occasion, and it's important for you as a clinician to recognize it when it happens. It's a pretty significant muscle spasms that happen that often affect the neck and or the eyes rolling back in the head or the tongue feeling thick for a patient. All of these are sort of classic for acute dystonic reactions. They're very uncomfortable for the patient. And we treat this fairly emergently with parenteral Benadryl diphenhydramine, which has a lot of antimuscarinic properties, and also benzodiazepines like lorazepam or Ativan. So important to recognize, particularly within the first 24 hours or so, if starting a drug or increasing the dose of a drug like haloperidol, to look for these significant muscle spasm issues called acute dystonia. The second extrapyramidal side effect that you may see is called akathisia, or inability to sit still with a lot of motor restlessness. Patients may do a lot of toe tapping, jiggling around, rocking back and forth, feeling like they can't sit still. Sometimes people feel like their skin is crawling. And it looks like they're agitated, and your instinct for a patient who, for example, has delirium or psychosis where you're giving Haldol, your first instinct might be hey, they're restless. I need to give them a little more of the antipsychotic, which, if it's akathisia, will only make things worse, not better. So like we saw with acute dystonic reactions, the first thing we'll do is we'll stop the offending drug, but then we'll look at whether or not another agent may make sense in the short term to help while the original drug that's causing the side effect washes out of the system. The third and differentiating kind of extrapyramidal side effect is pseudo-Parkinsonism, and this looks like someone with Parkinson's, a classic 3-cycle per second tremor, stooped posture, shuffling gait, muscle rigidity, and even sometimes pill rolling motions of the hands that look classically like Parkinson's. All three of these extrapyramidal presentations, they can happen each one alone or in combination, are related to the antipsychotic drugs. The agents used to treat extrapyramidal side effects are typically either antimuscarinics, antihistamines, benzodiazepines, or occasionally beta blockers. And all of these agents, usually the two we go with most often are the benzodiazepines in conjunction with Benadryl or diphenhydramine. That's particularly true for the acute dystonic reactions. The anticholinergics, per se, cogentin and artane, probably have a better track record in pseudo-Parkinsonian features where tremor's a big issue, but we don't see those used all that much anymore. The other side effects are anticholinergic side effects we've alluded to with all of these antipsychotic drugs, particularly the earlier first generation agents. And remember those: urinary retention, dry throat, constipation, uh, sometimes decreased sweating, tachycardia, blurred vision, and CNS changes with sedation and confusion. A long-term side effect with dopamine blockade, particularly with the older typical antipsychotics, is the risk after 6 months or more of continued use, something called tardive dyskinesia. These are abnormal involuntary movements, often involving the face. They're often irreversible. Older women may be at higher risk than any other cohort, but it can happen with everyone. And you'll classically see, instead of a 3 cycle per second coarse tremor that we saw with pseudoparkinsonism, you see more worm-like irregular movements of the body. You might see it in the tongue, you might see it lip smacking movements, tongue thrusting in and out of the mouth or in the cheek and out of the cheek, facial twitches of different kinds, rocking, rolling movements of the body or the hips or the neck. And they're pretty disfiguring for patients. They also are problematic, long term for patients who feel like, maybe we've used these drugs long term for paranoid features related to schizophrenia, and then this patient has these, disastrous kind of side effects. That kind of feeds into a patient feeling as though their healthcare team is poisoning them. So it becomes even more problematic that these really awful side effects related to movement disorders, among other things, uh, and uh, just really you want to sort of focus on all of these issues as being contributory to how dangerous these medicines can be, and when we use them, being careful. What I've included in the next 4 or 5 slides is a way that we will screen for tardive dyskinesia. And I encourage you to sort of read through this, but it's a standard procedure. I'll focus on a couple of areas here and highlight some key features that you'll see with tardive dyskinesia that helps sort of give you an idea what it looks like. We'll also sort of see if online we can post some videos of what tardive dyskinesia looks like, because watching a video is helpful. So there's a standard exam procedure that's done. You want to make sure that somebody doesn't have something in their mouth and that's sitting quietly when you do the examination. You also want to make sure the patient's as relaxed as they can be, and there's certain steps we'll do in the exam procedure, more steps for the exam procedure. And then the scoring tool is when you observe a patient, a 0 to 4 scale, meaning 0 is you did not see it. 1, you may have seen it. It may be extreme normal. 2, mild. 3, moderate. 4, severe. And so the numbering tool, while it's somewhat subjective, I think for clinicians who do this a lot, you become more fluent in inter-rater reliability when you're using this scoring tool. So among the things you'll expect to see with tardive dyskinesia is movements in facial expression, twitching of the eyebrows, or what looks like a tic, puckering or lip smacking, jaw biting, clenching, chewing, and tongue movement in and out of the mouth or in the cheek of the mouth. We often see rocking, twisting movements in the neck or shoulders or hip, almost like pelvic gyrations. And then overall, a patient may have some global sense of their movements and their awareness of their movements, and whether or not those movements affect their activities of daily living. Finally, because you're looking at so many oral things, you want to determine if there's any dental issues that could contribute to mouth movements as opposed to tardive dyskinesia. Our treatment of tardive dyskinesia primarily is prevention, meaning avoiding antipsychotics when you don't need them, lowest effective dose. And in line with this, because the first generation older agents were more associated with tardive dyskinesia, probably have a higher risk, we generally use the second generations agents when we need them because their risk for tardive dyskinesia is lower than the older first generation agents. But keep in mind, tardive dyskinesia happens over months. Instead of its direct effect on the dopamine receptor short term, what tardive dyskinesia likely is a change in dopamine receptors over time. And so what you'll end up seeing is patients who have uh, worsening symptoms over time with tardive dyskinesia. And then when you take the antipsychotic away, because there is actually a supersensitivity of those dopamine receptors, sometimes the tardive dyskinesia can actually look worse. But our long-term answer is to get rid of the antipsychotic when we can, to sort of prevent the severity of tardive dyskinesia from getting worse over time. There are a couple of treatments. The VMAT2 inhibitors are associated with inhibition of a vesicular monoamine transporter type 2, which offers some symptomatic benefit. But unfortunately, they have some side effects, including additional sedation. They also can prolong QT on EKG, and interestingly, all the antipsychotics to varying degrees prolong QT as well. Haldol, haloperidol, we didn't mention yet, has significant prolongation of QT that we worry about. So the best answer for tardive dyskinesia is preventing it. If someone has it, then we may look at stopping the antipsychotic when we can, using a second-generation agent if we need one, and looking at maybe one of the VMAT2 inhibitors. So that's not the only set of side effects we worry about with antipsychotics. There are many more, and let's go through some of them. One of them is something called neuroleptic malignant syndrome. This is seen more with the type older typical agents than is seen with the atypical agents, but it is seen with any of them, and particularly with long-acting injectable forms of the antipsychotics. What you'll see is increased temperature and muscle rigidity as sort of the classic presentation, often with a cohort of other symptoms like changes in consciousness, changes in blood pressure, sweating, tachypnea, tachycardia. It's seen in less than 1% of patients typically, and it's more commonly seen with the injectable long-acting once every 2 weeks or once a month IM injections of the antipsychotics. It can often develop within the first 3 days of these injections. And our management is just stop any further injections, but unfortunately, with neuroleptic malignant syndrome, if it's by injection of a long-acting agent, once you give it, you can't take it away. We'll look at cooling blankets sometimes, or cold infusion of cold fluids, and muscle relaxants, including dantrolene or some benzodiazepines. But those are really symptomatic management. The best answer is recognize it when it happens, stop any further antipsychotics. And you also want to look if a patient has an allergy or sensitivity to any one of these antipsychotics, which historically have also been called neuroleptics, hence the name. If they've had this kind of profile with one, that would be sort of a red flag that you would want to avoid all the antipsychotics, both the type 1 or the older typical agents and the newer second generation atypical agents. If you were to need one, I would strongly recommend that you weigh the risk and the benefit with a psychiatrist and perhaps a neurologist as well. Other side effects you'll see: increased risk for sedation, seizure risk with some of these agents. We already talked about orthostatic hypotension and liver function test abnormalities as well. And we see QT changes on EKG, particularly with Haldol, prolonged QT as well. So you can get the sense that the older typical antipsychotics, while someone who has very distressing symptoms of psychosis, it was a relief to find agents that treated those symptoms. All of these adverse effect profile makes these older typical antipsychotics difficult drugs to use, particularly long-term at higher doses. Hence the newer atypical antipsychotics, and most of them are listed here, both by generic and brand name. There are a number of them, and let's spend a couple of minutes talking about these. These agents, for the most part, work at at a serotonin level receptor a little bit, but they also work at dopamine 1 receptors. And so by working at less so at dopamine 2 receptors, but more so at dopamine 1 and histamine, a subset of histamine receptors, they're associated with similar beneficial effects and, in fact, better control of the negative symptoms of schizophrenia. These have also been used to augment depression therapy in folks who aren't responsive to antidepressants. But they have a varying profile risk. And you'll see across the top right, there are specific features for adverse events that correlate with different agents here. All of these agents are associated with some degree of weight gain, but some much more than others. And correlated with that weight gain is often a risk for diabetes developing. And that's certainly true for olanzapine and clozaril. And so you're really worried about that. You also see changes in lipid profiles, so cardiovascular risk plus diabetic risk become really problematic with the use of some of these atypical antipsychotics, particularly clozapine and olanzapine. They also vary in how sedating they are, the degree to which they prolong QT interval, whether they can be associated with extrapyramidal side effects that we alluded to, although all of these agents less so, and all of these agents likely have a lower risk for tardive dyskinesia as well. But that's not meaning that they don't have any. And so you want to sort of be careful with all of these agents when you sort of see them used. In practice, the ones I think that you'd see most often, at least that I see most often used, almost all of them actually, aripiprazole or Abilify is sort of unique among this group in that it seems to have some action at the presynaptic level as well as the postsynaptic levels. So aripiprazole is kind of an unusual agent because its mechanism is a little different. I don't usually see Abilify used in many schizophrenic patients or patients with schizophrenia, but you may see it augment therapy in depression or some other indications as well. Of the rest of the agents, there are a couple on here that have sort of a unique profile. I'm going to skip down to a few of them and then end up with clozaril or clozapine. If you go down further, about midway is Latuda, lurasidone, and Latuda, primarily I see this drug used for treating mania or mood disorders. I don't usually see it used in schizophrenia, but it has a role there. And it is pretty well tolerated in the sense of weight gain and diabetes risk is relatively low. So that's kind of given it sort of a benefit. The next one on the risk, olanzapine, is unfortunately associated with a lot of weight gain and diabetes risk. And so olanzapine, while it's pretty effective, is an agent that a lot of clinicians try to avoid. The two drugs that are related are Invega and Risperdal. And Invega is actually the active metabolite of Risperdal. And they sort of have a unique profile. Risperdal has a fair amount of extrapyramidal side effects that make it render it a little more difficult to manage and use. The agent I see clinicians reach for the most in older patients who are a little agitated it might be, if using any antipsychotic outside of schizophrenia, is Seroquel or quetiapine. It's a little bit sedating, more so than the others. A little goes a long way for patients. They usually tolerate it reasonably well. That's the agent I see clinicians reach for the most. And finally, at the bottom of the list here, Geodon is probably associated with the highest risk of all of the agents here for QT prolongation. And so we worry about QT with any of these patients, but particularly with Geodon, probably more so than the others. So these atypical agents work primarily at blocking dopamine 2 receptors and to some degree serotonin or 5-hydroxytryptamine receptors, particularly a subset of those receptors known as 2A. They have sort of other binding effects, but less so than the older typical agents do, so they're probably better tolerated, less tardive dyskinesia risk, fewer extrapyramidal side effect risk, and better efficacy for negative symptoms, those things that look like depression. And in fact, these agents are often used for augmenting patients who don't respond. The agent I didn't talk about, and I wanted to refer to here, is clozapine or clozaril. Clozaril, consider this the drug, the antipsychotic of last resort. This would be the antipsychotic clinicians would reach for when they've tried 2 or 3 other agents that have not been responsive. Patients who don't respond to other therapies seem to respond or often respond well to clozaril, but The problems are that clozaril has an adverse effect profile that is probably the most notorious of most drugs we see. Clozaril also has what we call a REMS associated with it, a risk evaluation and mitigation strategy from the FDA. Pretty significantly so, that because of the adverse effect profile, patients have to be registered in a national registry and get frequent lab testing, particularly their absolute neutrophil count, assessed while they're on clozapine. In addition, there are lots of side effects we see with it, and so they're going to be contraindicated in folks who have any bone marrow suppression issue, folks who have seizure histories, folks who have significant CNS depression, and we're really worried about its use or careful about its use when folks who have liver or kidney disease, cardiac disease, or a host of other concerns. The adverse effect profile is significant, the worst of which, or the most notorious of which, is agranulocytosis, suppression of bone marrow. Most importantly are neutrophils, but you can see a suppression in red cells and in platelets to some degree sometimes as well. We also see dose-dependent seizure risk, hypersalivation, hypotension, drowsiness. All of those are dose-related. And so because of these dose-related adverse effects and the side effect profile, clozapine is a drug that we typically have to start initially at a very low dose and work our way up in increments of dosing until we get to the therapeutic dose, which for most patients is around 300 milligrams a day. And so that may take weeks for us to get there. And then we are careful about anybody who has missed more than 48 hours of their clozapine because we have to then retitrate them again because we're worried about these side effects. All patients on clozaril need to be registered in a national registry, and we get their white blood cell count and look at their absolute neutrophil count on a regular basis. And the protocols for how often we do that at baseline and then every week or 2 weeks or a month, depending on their sort of subset of conditions and how long they've been tolerating clozapine. There's a national registry that's been in place now for about 4 or 5 years. And it's one registry as opposed to there used to be a couple of different registries for clozapine. And so clinicians who use clozapine need to register make sure the patient's registered. If you inherit a patient on clozapine, you are required to make sure the patient is registered and that you get a white blood cell count and you look at what their history has been. Has there had an interruption in their clozapine therapy in the last 48 hours? If so, we'd have to retitrate them after we get them confirmed at the registry. This graphic is a little busy. It's not, I don't think, critical that you sort of do anything more than have a familiarity with this and then go to the reference when you need it. But when you're registering the patient, there's concerns for how we consider patients who are either have a baseline neutropenic but a benign neutropenic history or a patient who doesn't have that history, and then what sort of markers or levels of a white cell count are acceptable for starting or continuing a patient on clozapine. Okay, so clozapine or clozaril, consider this if you've ever played the game Candyland as a kid, if you know that game at all. It was a little board game for kids who were 4 to 6 years old, probably one of the first board games I remember playing. And you would kind of go up the ladder and pick different cards to move your token up until you finally got to the winning space. But the issue was occasionally you'd get near the top and you'd pick a card that would have to have you start all the way over at the beginning again. And in a sense, this drug is like that. If you miss more than 48 hours of dosing, you have just picked the card for that patient to retitrate the dose from the beginning, to start over. Instead of starting them back on 300 milligrams a day, you've got to start them on 12.5 twice a day, and then go increase dosing from there. Okay, so important for you to recognize that. Okay, let's talk about a couple of the other atypical antipsychotics. Olanzapine we alluded to. It works pretty well, but the big issues we worry about is the weight gain and diabetes risk. And so olanzapine is not a first-line agent anymore for most clinicians. But because it does cause a fair amount of sedation, I have seen clinicians who have found a patient who has significant episodic agitation that is to the point of being assaultive, for example, in the hospital, occasionally reach for this drug. If it's worked in the past, there are different forms that can be given, an orally rapidly dissolving form as well as injectable forms. But long term, we worry about this drug used long term because of diabetes risk. Risperidone has been around for a couple of decades now, and it's available both as a short-acting formulation orally and different long-acting forms, either as the parent drug or the active metabolite of it. And the long-acting formulations are the more common use for these drugs. There's a couple of other alternatives like these drugs available on the market as well. The problem is that risperidone itself, at least, has a fair degree of extrapyramidal side effects when we get doses above 4 to 6 milligrams a day. And so it begins to behave and bind to the dopamine 2 receptors in a way that produces some of these movement problems we saw with the older typical agents. Quetiapine, or Seroquel, is sort of a pretty well-tolerated agent, can cause some sedation, and that sometimes is significant, but that's often why it might be used. It's pretty well tolerated of all the agents. It's the one I see clinicians who are hesitant to use an antipsychotic but need something that's going to be a little more sedating will often reach to in low doses. Geodon, we alluded to, has a QT prolongation risk, and so this drug, probably because of that alone, is enough to say that it's probably going to be a drug, a second line or third line, and probably used by a clinician who uses these drugs a lot and has determined that drugs that don't prolong QT to the same degree have not really worked well for the patient in question. Aripiprazole, or Abilify, is a little bit different in that it works at the presynaptic dopamine receptors, and so it has some advantages. It doesn't have some of the same side effect profile as the other agents, but a lot of clinicians indicate that it probably doesn't provide as much of a robust response that you would often see. Another issue with all of the antipsychotics, but particularly aripiprazole, is a fair number of drug interactions that affect the cytochrome P450 enzyme systems. And so you'd want to be pretty much aware of that. And then there's a list of some of the newer atypical antipsychotics. And some of these agents I list here have been around for the last 4 or 5 years or so, some more so than that. And probably of all of them, I'm only going to focus on 1 or 2 of them. The rest of them really have a role, but they're going to be more expensive for patients because they're still only available as brand name product, and they may or may not have that much of an advantage over existing drugs. Latuda, though, has the advantage of its use in mania, and it is fairly well tolerated with less sort of some of the adverse effects. And so because of that, it is more commonly we see this drug used in patients in mental health, either with mania or sometimes with psychosis as well. The other drugs that are listed here have some more limited use from at least my perspective because they're newer. Their use is usually limited to patients who have been refractory to some of the older second-generation agents when the niche sort of fits for them. But I'll tell you quite honestly, these are not, at least from what I see patients coming in the hospital for, are not all that commonly used. The next sets of tables here, sort of as we wrap this topic up, refer to the degree of metabolic syndrome and sedation and QT prolongation and other kind of side effects for some of the different agents that are listed here. So I encourage you to sort of look through this. Just differentiating, I think it's important. On this slide, you have a familiarity with Abilify, that you really understand what makes Clozaril, particularly its side effect profile, sort of unique compared to all the others, and the unique nature of Clozaril use. On this slide, I think the ones you'll see, virtually every drug on this slide and the second set of slides, you will see used in practice to varying degrees. So helpful to begin to differentiate them. Recognize that Geodon probably has the highest risk for prolongation of QT interval. There are lots of adverse effects and drug interactions with among the antipsychotics and the cytochrome P450 enzyme systems. And so you don't need to memorize this table, but you need to recognize that, as we see with lots of the drugs in mental health, these fat-soluble drugs will be metabolized, and many of them via these enzyme systems that are genetically influenced and can interact with many other drugs a patient may be on. Okay, so in a nutshell, that's the antipsychotics. Those are kind of the tools in your toolbox. How you think about these agents is what is both, does the nature of the condition mandate that I consider an antipsychotic? Usually you're going to have a second opinion on that. More often, your role is going to be continuing an antipsychotic, but recognizing all the adverse effect profiles that the antipsychotics can have. And we'll try to sort of reinforce this content when we're live and in class. Excellent.